So my inpatient work is with patients with oncology and gastrointestinal diseases, and my outpatient work is here. It's in the center of pain medicine and mental health, and there I see patients with chronic abdominal pain and fibromyalgia. So I know because I work together with patient organization that it's not easy for German patients diagnosed with fibromyalgia to be taken serious by the medical doctors. Still, it's a problem. And it's always also not easy for us, for researchers, to get big funds in Germany, because fibromyalgia still is a disease with low prestige. And I was surprised to see the study conducted in Norway, that fibromyalgia ranked 3 times in 1990, 2002 and 2014, and the lowest rank of prestige by general practitioners. I think some GPs are here and you have a different opinion, and I hope that this seminar will change the minds of your medical doctors, will improve your clinical care, and will also improve your collaboration and research, and I keep my fingers crossed that you will have success. So I also have a lot of conflicts of interest, but the Cochrane collaboration and the drug commission of the German Medical Association weaned me off of any financial conflicts of interest in the last 3 years. So, but I have a lot of academic conflicts of interest, so I'm engaged in the German and in the European guideline on fibromyalgia. And I have to confess, even if I prescribe drugs to patients that have a strong emotional bias towards exercise and psychotherapy. You will recognize it during my lecture on management. So, I will talk about what diagnostic criteria for fibromyalgia syndrome. Please allow me to use this term because in Germany we agreed in our guideline to use the term fibromyalgia syndrome because it's not a distinct entity, as Dan Claw pointed out, but it's a syndrome. And it's defined by symptoms, and therefore we call it symptom as we call it irritable bowel syndrome. So I will talk about which diagnostic criteria are available, which diagnostic criteria I recommend to use. And I think because there are a lot of GPs in the room, aren't you? So I will just say how I make the diagnosis, because I see at least 4 new patients a week which are referred to me with the question, is it fibromyalgia or is it something else? So one important thing that this first criteria from the American College of Rheumatology in 1990, they were classification criteria. They were used to define a clinical entity, but they were never intended to be used as diagnostic criteria, but they were used as diagnostic criteria. So what were the reasons for Fred Wolf and other American rheumatologists to leave these classification criteria and to develop new criteria? There are several reasons. One is applicability. Only rheumatologists were trained during their fellowship in tender point examination. And GPs, neurologists, they are not acquainted with it and they didn't use it. The other thing is that even rheumatologists had a very low inter-rater reliability when they tested these tender points. And it was never be tested if these tender points examination was as reliable as is were done by GPs or by neurologists. Another important point is that this clinical tender point examination was not reliable, because it's very much influenced by the expectation of the patient and expectation of the medical doctor. So in the time I use it, so I knew some patients, even if I showed my thumb, they started to twitch, even if I had not touched them. Now this was a kind of learning process. And the other one is, if you did not use a dolorimeter to make a standardized pressure of 4 kilograms, and you used only your thumb, you were biased by the medical history which you took with the patient. He reported symptoms and you think, oh, it might be fibromyalgia. And the more you believed in fibromyalgia, the harder you pressed, and the more you get fibromyalgia. So one of my German colleagues, Wolfgang Eich, he was, I think 10 years ago here in Norway, and he talked with a Norwegian epidemiologist, and in their area they had a very high prevalence rate of fibromyalgia, and he said, oh, how do you explain it? And it was a female researcher, and it was a great Nordic woman. No? So she said, oh, I have a very strong pressure of my thumb. So on the other thing, in sum, tender point examination was complicated to do for most physicians, and there was a strong correlation between the number of tender points, at least in women, with other somatic and psychological symptoms. Therefore, Fred Wolf and others, including Dan, developed new criteria, and these are the 3 new criteria available. Don't be afraid, they are very similar. This was, to my opinion, the last diagnostic criteria which were endorsed by the American College of Rheumatology in 2010. And they were modified in 2011, and the last, and hopefully last, revision was in 2016. So what are the main changes compared to the 1990 criteria? The criteria should be clinically applicable by each physician. Therefore, no tender point examination is necessary. And the real aim is that fibromyalgia or fibromyalgia can be diagnosed by every physician. It does not need a special training. And the second change is that the diagnostic criteria include not only pain but other symptoms like fatigue and unrefreshed sleep. And the scale of the 2011 criteria also allows you to make a severity scaling of fibromyalgia. Now, this was the 2010 criteria, and they were based on the physician when he was taking a medical history of the patient. So he asked how many pain sites the patient has, and if he has other symptoms like fatigue and unrefreshed pain, and he could ask the patient a lot of other symptoms, and there was a mixture of somatic symptoms, of psychological symptoms, but also of findings like Renault symptoms. So again, these criteria, which put a lot of work to the physician, were not very suited for busy GPs. And they were also not applicable for survey purposes because it always needs a medical doctor. So therefore, there has been a modification of this 2010 diagnostic criteria. These are the modified criteria or the 2011 criteria. And there is a simple questionnaire available which has been translated and validated in different languages, and you also do the Norwegian validation study. So you see here, you can have a maximum of 31 points. 19 points are self-report, how many pain sites you have. The other one is on fatigue, trouble thinking, unrefreshed sleep, and you see they are highly weighted, and there are 3 additional symptoms. Frankly spoken, I was not very happy with these 3 symptoms. I would have preferred other ones because this induced a much bigger overlap to irritable bowel symptom and headache. But if you would substitute it by paresthesias, it would come to the same. So nevertheless, the questionnaire has some difficulties for psychologists because you have different scaling, you have different time frames, but nevertheless, this questionnaire, a self-report questionnaire for a patient, works very well and is more and more used also in clinical studies because it gives you a measure not only of widespreadness of pain, but of other psychological and somatic symptoms. Though is for, let's say, a somatic and psychological symptom burden, and you then use it as a measure of central sensitization. So we medical doctors are forced to make a diagnosis. And now I will explain how we'll make a diagnosis based on this self-reports of the patients. You can make a cutoff, and this cutoff is very well founded by a lot of statistical procedures. If you have a sum score of 13 and more. And the 2010 and 2011 criteria said you can diagnose fibromyalgia if you have more than 7 pain sites and the symptom severity, these are these 12 points, is above 5, or you have at least 3 pain sites and the symptom severity score is above 9. And the symptoms must be present most of the time in a time interval of 3 months. And now there's a big problem in the criteria. The 2010 criteria stated that it needs the exclusion of a somatic disease sufficiently explaining pain. And this was changed by the most recent revision. It was a 2016 revision. What the changes are only slight. One is that it needs more pain sites, not 3 but 4. The reason was one study conducted in Switzerland which demonstrated that patients with regional pain, especially irritable bowel syndrome, would meet fibromyalgia criteria because they have a very high somatic symptom score. Therefore, Fred Wolf changed it into 4, at least 4 pain sites. And in addition, just to keep the idea of widespreadness of pain, they defined a generalized pain sites in at least 4 or 5 body regions, that is the extremities and the spine, except face and abdomen. And the diagnosis of fibromyalgia is valid respectively of other diagnoses. This is a change. The fibromyalgia, as pointed out, can be diagnosed and can exist with any other disease. I will point out the problems you will face if you're a neurologist or internal medicine or GP in some minutes. So, what can a problem still remains? This is a problem of cutoff if you define a diagnosis. Here in this, either if you use the medical doctor's report or the patient's report to say, I diagnose fibromyalgia syndrome, a certain cutoff has to be surpassed. And it's a score of 12 or 13. And this was the same with the tender points. 10 of 18 and tender points were required. So, or 11, sorry. So the question was, what do we diagnose if the patient has 9 tender points? And what is with the patient who has a score of 11? So I think we face this problem with every continuum disorder if we set a set point. So there's no real border where diabetes or hypertension starts. It's always up where you defined the threshold. And so in the years we lowered the threshold for hypercholesterolemia, for hypertension, and of course you can change all the threshold if you say now it's fibromyalgia. In patients who were previously diagnosed with fibromyalgia and have now a score of 11, 12, or they can say they have a little bit recovered. This could be one way to use the score. And we have also the discussion if there's something what we call sub-threshold fibromyalgia or beginning fibromyalgia. But again, it's a problem of wording if you use this idea of a continuum of fibromyalgia-ness. So we must keep in mind that these diagnoses are not diseases and they might change. So what is important for me, for colleagues as GPs and general internal medicine, is to point out, because we're always afraid if a patient comes to us and he suffers from pain, that we miss a somatic diagnosis. and that we diagnose fibromyalgia as a wrong diagnosis. And it's true, chronic widespread pain is not always fibromyalgia. And this is a recent article I wrote with rheumatologist, neurologist, in which, and it's open access available in Pain Reports, in which we pointed out that other diseases can mimic fibromyalgia. So I'm working in the setting of oncology, and some of my patients with multiple myeloma or advanced prostate cancer with anemia and bone metastasis, they really would have at least 14 or 16 points on the scale. And it would make no sense to diagnose fibromyalgia in patients with advanced cancer. Though it depends on the setting where you're working. If you see a patient with chronic widespread pain, the question is the probability to which you will receive a real defined somatic disease, or it will be some kind of chronic pain disease. Therefore, we recommend a stepwise approach, and this is what I want now to talk about. So one thing is give every patient who comes to you with chronic pain, even if he reports only a local pain like headache or chronic low back pain, give him a pain diagram. And this pain diagram can give you at a glance the idea what is going on with the patient. This is the patient with abdominal pain who came to me. But you see, this is not only abdominal pain. This is really widespread pain or generalized pain according to the 2016 criteria. It's pain in all the four extremities, in the spine as well, not included in the 2016 criteria of widespread of pain in the head and in the abdomen. So if a patient comes to me and complains about pain, I ask him, how long is it pain? And if you have multiple pain sites, is this pain always the same in all pain areas, or is the maximum point of pain, is it changing all the time? And if it's widespread pain, you can ask the patient, how do you wake up in the morning? And if somebody is telling you, oh, I feel as if a truck has run over me in the night, then it's what I hear of the patient. This is a very typical example of feeling unrefreshed. And then you can make an open question. So how about your concentration? How about your physical fitness? Did it change in the last month or years since you have the pain? These are very simple questions, but if the patient shows you chronic widespread pain in the pain diagram, and he reports to your open question on unrefreshed sleep and decreased mental and physical fitness, then you have a fibromyalgia type of cluster of symptoms. And this you can have within 2 minutes of asking and discussing with the patients. And then, of course, you can ask, have you any other medical problems? And then you will get of a lot of patients' reports, or all of chronic gastrointestinal problems, have 3 endoscopies, and they all have some problems with the urinary tract. Again, if you are a GP, you should also ask for some red signs, red signals like reduced appetite and fever. This gives you a hint that there might be some other causes of the widespreadness of pain and of fatigue. And of course, for the first evaluation, it needs a complete medical and psychosocial history. So ask if you have any other disease, do you take any other drugs? Because there are some drugs which might also cause muscle pain and joint pain. And it needs a full physical examination with specific attention to body tenderness, dysesthesia, but also for some clinical signs of inflammation like joint swelling or entasis. And it needs some exploratory neuroelectrical examination. And so it take for me 30 to 40 minutes to have this complete medical history and medical examination. It's prepared by questionnaires which are sent to the patient in advance. And then most of them, they bring with them a lot of laboratory tests and also X-ray. This is not necessary to make the diagnosis. So I also say patients, if they come to me with, is it fibromyalgia or not, I say there are in medicine two types of diagnosis. There are diagnoses you can establish and base on laboratory findings or on X-ray. And there are some diagnoses which are symptom-based and which are based on symptoms, and I check if the symptoms the patient reports meets predefined criteria. One example is headache. There are a lot of types of headaches, and nobody would question that there's migraine. Even there is no lab test and no imaging to diagnose migraine, but it is a very typical history, a cluster of symptoms. And I diagnose migraine very surely by the symptoms. And I can make the same for fibromyalgia. It's a diagnosis which can be, in most cases, established by every physician. And to be sure, not have something missed for initial evaluation of a patient with chronic widespread pain, all the guidelines recommend some basic lab test just to check if there is some signs of inflammation, if there is some signals of a muscle disease or of a thyroid disease, which also can mimic chronic widespread pain. So if you have a history without any other medical diseases, if your physical examination shows you only the symptoms of tenderness all over the body or in many parts of the body, and you have no signs of another disease by your medical examination and your basic laboratory tests are normal, then every GP can diagnose fibromyalgia. Of course, there might be some signs, some symptoms the patients report in his history, or some signs you have during the medical examination, owing some laboratory tests, which might give you a cue for other somatic diseases, which might completely mimic or might be part of the chronic widespread pain. I do not want to go into details. Again, this paper is freely available, and you see the medical history and as well as the clinical signs, which should raise some suspicion of another somatic disease. And the medical history of patients with chronic pain, and especially in patients with chronic widespread pain, should also include some screening for psychological symptom burden and psychological distress. This, we should be interested in the whole patient. And in our German guideline, we recommend the Patient Health Questionnaire 4. It's very simple, and it's very simple to use in every practice. And you see this first two questions are on anxiety, and the questions 3 and 4 are on depression. And you can make a very simple score. You see, for anxiety as well as for depression, the highest score is 6. And if you have a cutoff, a value of 3 and more in each scale, this is very suspective with a very high reliability and validity of an anxiety and depressive disorder. And this is also important for the management we will later talk about. So, in sum, there are some guidelines, recent guidelines from Canada, Germany, Israel available, and they always recommend the same approach. What is necessary to diagnose fibromyalgia? It needs a history of a typical cluster of symptoms, and it needs the exclusion of some diseases which might completely explain chronic widespread pain fatigue, or at least to identify some diseases which might have an impact on some symptoms, on some pain sites. Therefore, this topic of exclusion of somatic diseases sufficiently explaining chronic widespread pain or not is still under debate. We can have diseases which completely mimic fibromyalgia symptoms, but which can be cured by medical therapy, and then it's not fibromyalgia. But this is very rare. So very rare in GP practices and very rare in general internal medicine. I think it's something different if somebody's coming to a rheumatologist. Some of these patients, although with chronic widespread pain, might have mild inflammatory rheumatic disease. So I just want to highlight what Dan Claus said. It's not either it's fibromyalgia or it's something different. We see a lot of combinations of fibromyalgia. And in my medical reports, you see very often I write, this patient has chronic widespread pain, he has fibromyalgia, but he also has some myofascial pain syndrome. He also might have a slightly active inflammatory rheumatic disease, and he also might have polyneuropathy. So we really have one patient who has small fiber neuropathy, really with typical symptoms, and fibromyalgia. You can have both. So that is to say that if a patient meets fibromyalgia criteria, it must not be the only diagnosis and must not be the most important diagnosis. It's only to acknowledge that the patient has symptoms that satisfy fibromyalgia criteria. And it's up to you to decide on the meaning and the importance of the clinical findings. So what is more important? The neuropathic pain component or the centralized pain component? This is a clinical decision. Should I stop now and about severity in 10 minutes?